So we'll say someone came to you, a patient. Hi, my name's Joe Blogs. I'm 20 years old, male. They're always male. Let's make it a female for a change. Let's say Joanne Blogs, female, 20 years old, diagnosed with autism 5 years ago. I've been following the carnivore diet. I've been doing, beef, butter, bacon, and eggs. I think that's a popular one. And I've been doing that for 3 months. I feel quite good, but my mood's still not lifted. I'm still quite fatigued. What do you then say to that person? Like, what is your first port of call, and maybe branch out from there?
Sure. So what I typically do, and this is speaking generally, obviously it will be based on the individual, but when a patient comes to see me and they really want personal management of things like this, before the first time I see them, they will be sent a list of what I need, so that when we speak for the first time, I'm not just saying, what's this, and fact finding. I can get that done before. So I want a full diet history, ideally for about 3 weeks afterwards, if not, at least 2. And I want pictures of those foods as well, so I can see the size of the portions and things like that. And I want them to list any symptoms. Do they actually feel full? Are they still hungry afterwards, etc., etc.? And then I want a history of their lifestyle. So for example, roughly speaking, how much sleep they're getting, when they're inside, when they're outside, what kind of exercise are they doing, what medications, the dose, the timing, etc., what supplements, all those things. That allows me to build a rough picture of who it is that I'm going to see before I've actually seen them. And then I can say, well, you're a little bit deficient here, a little bit deficient here. Let's start with that, optimize everything, and then go from there and address individual symptoms if they're still not fixed based on that. As an example, let's say they do no exercise, and their body weight for their height is relatively low and they're pretty skinny looking. I would say, okay, regardless of whether you're autistic or have this problem or that problem or no problem, it's pretty universal that muscle mass is required for optimum physiological function. So let's tick that box anyway, and then reassess the autism aspect. So we would do a job of box ticking things that are universal and then come back to the autism. Let's pretend we've ticked all those boxes to do all that stuff. And the autism is slightly improved, but still not completely disappeared. The first thing I would say is, well, it's not something that will disappear straight away. We know that, for example, diabetes can take 20 years to develop, Cleve 1974. And all these chronic diseases are called chronic for a reason. They take a long time to develop. Most likely, they will take a long time to go away, because taking place over a long time means the damage is probably quite high. You can't instantaneously reverse damage when it's chronic. And so the repair has to be chronic as well. If they've had an improvement, I would say, okay, let's carry on. Little bit by little bit by little bit is absolutely perfectly acceptable, as opposed to expecting an instantaneous reversal. Now, if they have the budget, we might look at other things that might help in that repair aspect. And again, this is individual. I don't think this is a default thing for anyone to do. But for what it's worth, for your viewers' information, here's a couple of things that I might do. NAD plus is something that I use quite a lot. Very specifically, it's not that everyone can just go in and shoot themselves up with it. There is a safe way and an unsafe way to use it. But that is something that has shown huge promise in neurodegenerative disorders, in metabolic disorders, etc., especially in combination. In my personal view, it has to be in combination, in fact, with the correct diet and lifestyle boxes ticked. So NAD plus is one that I would look at, and we can chat about that if you like. And that's the main one. Potentially, I would also look at things like glutathione. Now, one of the reasons, we mentioned NAC earlier, N-acetylcysteine. One of the reasons people take N-acetylcysteine is to increase glutathione production, because glutathione is a tripeptide, glycine, cysteine, and glutamic acid, I think, unless someone corrects me in the comments. But the cysteine is part of that backbone of that tripeptide. So if you take the cysteine, a certain amount of cysteine leads to a certain amount of glutathione, whatever that may be in ratio for that individual. I'm not going to try and work it out because it's impossible, but it's a certain amount. However, a certain amount of cysteine will lead to less than that of glutathione for obvious reasons. You can have a certain level of inefficiency, not a multiplication. What I prefer to do is actually take the pre-made glutathione in a pure form, not in a pill, in injectable form, and we will actually use that, and we will inject it exactly like a type 1 diabetic inject insulin. In fact, if you saw someone doing it, there'll be no difference visually between someone injecting glutathione and insulin. Syringe is the same part of the body, same layer within the skin, just not within the skin, but underneath the skin, etc. They're two ones that we commonly use. And I personally have seen really good results with it, not just in things like this, but other neurodegenerative conditions like Parkinson's, dementia, mentioned Alzheimer's already. And it's really, really promising. As a matter of safety for the viewers, please don't think that I'm saying go out and buy these things and do it. The emphasis is on the fact that there is a safe way and there is an unsafe way. And the best way is to see someone that knows what they're doing and then learn from them what is best for you individually.
That's interesting. You brought those two up because I've used both of those recently. I found that the NAD plus was effective. You do find an energy boost from it, but it was almost as if I just got fed up with jabbing it. It was a bit of it stung a little bit.
Yeah,
a little bit of a sting. And when I say a sting, guys, it's not like agonizing. It's just if you inject yourself with different things, you don't want to be doing it all the time because it just hurts. But so I had one question about that, and a secondary question. So one was, can you just microdose it, or is it better to use as a large kind of, a bolus drip sort of thing? So that's my first question. If you want to answer that one,
that's a very, very important question to ask, because that's one of the differentiators between safe and unsafe use. If you look at what's available on the market, just for a second, and we'll come back to the question, you've got pill form and then you've got needle form, shall we say. Pill form is self-explanatory. Needle form, you've got exactly what you just said, Jonathan. You've got the microdose where you inject a little bit into your fat, like every day, every other day, whatever the protocol is for you. And then you've got an IV form where the needle sits in your arm for about 6 hours, 8 hours, something along those lines. Anyone watching this, please listen very carefully as a matter of your own clinical safety. The average person should never go and get an IV drip of NAD+. It can be extremely dangerous. If you are severely depleted of, let's say, water, you can drink a lot of water and be safe. If you're not that dehydrated, you only need a little sip. Very simple to understand, but the principle is identical for NAD+. Now, you don't feel a thirst for NAD+, which is what makes it difficult to know how much you individually need. And again, that's why you should see someone. But as an average, as a generalization, NAD+ IVs started in the 90s in Tijuana in Mexico. And a really great man, John Gillen, was there at the time. And John saw that this was being done for people with alcohol-induced liver toxicity, i.e. people whose livers had basically said, I'm done. They were on their deathbed. They were given IVs of NAD, in fact, multiple IVs of NAD. And in 5 days, they were just walking around, jumping like nothing had ever happened. Because there's one thing that depletes NAD in the body, it's alcohol, as John always says. So in that situation, because they were so depleted, they needed a huge jug to fill it back up. Now, if you are not in that situation, let's say you're only slightly below the rim on your bucket of NAD, but you pour a bucket full in there and you get the spillage on the side, then you're in trouble, because NAD does not exist as purely NAD in isolation. It is a reversible reaction between NAD plus and NADH. And there lies, in biochemical terms, if you remember, Jonathan, a little bit of something called an equilibrium constant. Based on what the equilibrium constant is, it is more to this side or more to that side. And again, that might even be temperature dependent, depending on what context you're studying it on. But you have that ratio. And the ratio is meant to be, just for argument's sake, I'm going to do it on camera here as my two hands next to each other. Let's say that's ideal. If NAD plus drops and you give the exact amount to get back to normal, good job. Let's say it drops a little bit, but you go way up here, you're better off because you're still out of balance. You've just swapped one problem for another, and you're going to get symptoms relative to that. Then you come on to the microdosing, which is what you've mentioned before. The microdosing is where you take a very small amount, small meaning relative to what is available in an IV. And you take that in an individual way that might be, as an example, something like anywhere from 20 to 50 milligrams, something like every other day, potentially every day, depending on the context that you are in.